This is Oliver Monfredi reporting for Heart Rhythm TV, and I'm delighted to say that this evening we've been joined by Dr. Charles Love from the Johns Hopkins Hospital, Director of Cardiac Rhythm Device Services. Thanks for joining us, Dr. Love.
Hey, great to be here with you, Oliver, and to be your first interviewee on Heart Rhythm TV.
Absolutely. I wanted to ask you what you see as the biggest challenge facing the field of lead management today.
I think there are two areas that I think are really, really important. The first is one that we struggle with daily, and that is getting patients who have infected cardiac electronic and implantable devices to definitive therapy, which is extraction in most cases. We know that by the great work done down at Duke, shows about 80% of patients do not get to definitive therapy in a timely manner. And patients that are put off more than 6 or 7 days have significant higher morbidity and mortality rates. So using electronic health records, screening tools, educating your colleagues, trying to get these patients into definitive therapy where we can save their lives, and it truly is life-saving therapy. This is perception that lead extraction has a really high mortality rate. When I poll audiences of cardiologists, the perception is 5 to 10% mortality rate, when indeed it's less than 1%. So we have to get that word out. The second big issue is just starting to evolve, and that is this whole issue of tricuspid valve repair and replacement that's being done percutaneously by our structural colleagues. And what's happening is these leads are getting jailed in place. They're getting abraded by the clips that they're putting in, and it's becoming a really, really big problem.
Yeah, I mean, a real big concern and a hot topic in the field, both of those things. Referring to the latter, are there any data or any anecdotal experience that you have of extracting jailed leads, and what sort of techniques would you favor and what things would you take into account when faced with extracting a jailed lead?
So I think first of all, to address, are there any data? And the answer to that is no. There have been no prospective studies and probably not much in the way even of retrospective studies, but there are anecdotes. So I've taken some leads out that have been jailed inside stents intravascularly, and certainly leads that have been stented into place in the tricuspid valve annulus by a new valve, and even sewn into place by a surgeon who has replaced a valve. And those can be very challenging because you're going to either break the lead off at the annulus, or you're going to create a hole, potentially a little fistula there at the annulus if you bore through there with an extraction sheath. Sometimes you get lucky and you do a little traction and the lead slides out from that area. Other times you have to use a sheath. I try to use the smallest sheath I can, and I actually have even used the old school polypropylene sheaths just to try to gently nudge in there, not vaporize a big hole with a laser sheath or grind through with a big mechanical sheath. So those have worked well for me in the past.
Excellent. And what would you recommend electrophysiologists across the world do when faced with this looming threat of leads potentially being jailed by percutaneous tricuspid valve replacements?
I think that's a great question, and like all areas of medicine where we have these multidisciplinary issues going on between surgeons, in this case structural heart specialists within our cardiology groups, and our electrophysiologists that implant and extract leads, a multidisciplinary approach is going to be the right thing to do. To sit down, number one, talk to our structural heart experts so they don't jail these in. And prevention is the key here. Prevent us from ever needing to extract a jailed lead. Leads get broken because when they are pinched between the annulus and the structure of this new valve, there's a flexion point there. So leads will fail by either fracture or by failure of the inner insulation or by abrasion of the outer insulation and then the inner insulation. Same thing if you put clips in. Those clips can create abrasion points for leads if they are rubbing against those clips. So one is to prevent that from happening. Let's talk about getting leads out before we place these valves. We now have leadless device technologies, both single and dual chamber. There's a lot of different ways we have great subcutaneous ICDs and extravascular ICDs. So we don't need to get into the right ventricle with leads much anymore to accomplish good pacing and even physiologic pacing. So that's number one, is prevention. And number two, if we are in a situation where we have to extract the lead, something's become infected, which is going to be the main reason, then I think consulting with our structural heart experts and our cardiac surgery experts, just to make sure everybody's on the same page before we go and try to do these things. But absolutely, prevention is worth a pound of cure here. An ounce of prevention is worth a pound of cure. Don't gel these things in. Don't put the clips in there where they're going to abrade the lead so we don't have the problems. It's safer and easier for us to get these leads out before they put the new valve in. Then we can put a coronary sinus lead in for LV pacing. We can put a leadless device in either before or after they put the new valve in. We can extract, place a leadless device in, and we can do, again, subcutaneous or extravascular ICDs.
I think that's phenomenal advice. You know, I think I get the impression that sometimes the potentially disastrous consequences of jailing these leads is really not, you know, fully appreciated ahead of time by certain, by certain implanters. You know, given your many decades, not too many decades, but several decades of experience in lead management and lead extraction, what one piece of advice would you give to the less experienced lead extractor that you wish you'd known about when you started out managing leads?
I think that the best advice I can give a young lead extractor is to utilize those of us that have a lot of experience. We are delighted to work with you. We are delighted to consult on cases and give you some tidbits of advice. There is a website called leadconnection.org, I believe it's leadconnection.org, which is run out of the Cleveland Clinic and was set up by our great colleague Bruce Wilkoff that has passed away recently. And it's a great place to exchange ideas. You can post cases and have experts chime in on it. You can email us, you can call us. We are absolutely delighted to speak with our colleagues. And you don't have to go it alone. We have decades of experience doing this kind of thing, and we can give you suggestions as to how to approach something to maybe make it a safer or more effective procedure.
That's great advice. I can definitely say that I've benefited on multiple occasions reaching out to you and several senior colleagues across the nation, and I would very much second that. You already alluded to Dr. Wilkoff and his recent untimely passing. I wondered if you would say a few words about his contribution to the field, which has been immense over time.
Thank you. Bruce was an amazing individual and did more for the field of pacing than anybody I can think of in the last 25, 30 years. I actually met Bruce when he was a fellow at The Ohio State University. He was a couple of years ahead of me in training, and he blazed the way at our institution for electrophysiologists to do implants in the electrophysiology lab. Prior to that, they were all being done in the OR by cardiac surgeons, and he blazed the way for that, which enabled me to get trained as well by the same person that trained him. He went on, of course, to be the anchor up at the Cleveland Clinic in device management and lead management. He had so many contributions with activity-based pacing, anti-tachycardia pacing, defibrillation, certainly lead management. You just can't say enough about what a great educator he was, a colleague, a mentor to us all, and an incredible researcher, being the lead author on the RAPID trial, which was the most recent trial using the antibiotic-eluting envelope, which was over 7,000 patients internationally randomized to envelope or not. We would not be where we are today in device therapy without the efforts that Dr. Wilkoff provided to us all. It's a great loss to all of us, but he left an incredible legacy.
Absolutely. A very fitting tribute. Thanks, Dr. Love. And we'll round it up there. Thanks very much for your time this evening. I really appreciate it. I'd like to, underline the fact that anybody with any questions about difficult cases, that you really are a phenomenal mentor and always happy to be to be approached about these things. And so, you know, I sincerely hope that people feel comfortable doing that. So thanks again. And we're looking forward to seeing everybody at HRS. Thanks, Dr. Love.
Thank you, Oliver.